All right, good morning. Just by a show of hands, how many fellows do we have? So all the fellows, are you guys, is this final year, you're kind of, everybody's leaving now after this year? Got to start working for real? Yes. All right, so good. I kind of targeted, I say know your audience. So I tried to target the audience appropriately. So these are my disclosures. I do work with BOLUS directly, and I have in the past been on.
And let me just put this on real quick here. Here you go.
Can you hear me? Can you hear me now? Yeah. Excellent. Okay. So this is the part where I tell you what I'm going to tell you. There'll be some introduction, but then we'll kind of go through components of the history. Are there differences in design of targeted drug delivery? I'll touch a little bit on cancer pain, and then we'll end up really talking about how I use targeted drug delivery in my practice, because it's completely changed how I practice medicine. So a little bit about me, and I give you this little background because I think understanding, I like to read, and so I think about some of my favorite authors. The reason I like them is because they spend the time for character development. You know a little bit about me, it'll kind of give you the appropriate bias as I talk, because anybody talking to you is going to give you their bias, and I think it's important that you understand that bias. So again, born in New Jersey, I'm an East Coast boy, was in the Air Force pretty close to 30 years, trained in the military. So basically, I'm an Air Force made dude. And so I think in a lot of my training, I was trained by 4 guys, 2 interventional radiologists and 2 neurointerventional radiologists. And you become a component of who's trained you. And so I want to tell you kind of what really sold me on pumps and why I have used pumps to kind of build a component of my practice. Again, I tell you, I'm military, so I train with a lot of people from uniformed services, and we ended up staying together sometimes for 8 or 10 years. You're practicing with the same people. So these are your friends you've known from day one in medical school. So I got approached by a friend of mine. She's an oncologist, and she says, I have this patient who's in just terrible pain. So I'm called up, I go see this guy. The room was pitch dark. Family can't even really enter the room. If you bump his bed, he screams. But this guy controlled fire control missions in Vietnam. So in his severe pain state, he regressed back. So the room's pitch dark, and he's calling out fire missions just due to his pain. So long story short, I called Medtronic's Cole and said, hey, how do I learn how to do this? They put me through a training course. That was around October of that year. He got his pump in November. He came back for his follow-up appointment asking me could he woodwork. He's got his little granddaughters at his side. He couldn't interact with her at all because of his pain. And basically about May of that year, his sons came back and said, you gave us 6 months of our dad back. My kids got to see their grandfather, but he had passed. But you have these ideas of why you enter medicine and what you want to do. Specifically, as people who care for other people's pain, you've entered a very kind of delicate and really an intimate component of people's lives. I think in some of the things that we do in medicine, we can kind of hold patients at arm distance. But in taking care of people's pain, you embrace them and you embrace components of their family. And they'll be kind of, and again, this is all anecdotal, but you know your science, but you kind of live by your anecdotes. And so now my eyes were opened. So look at the history of intrathecal targeted drug delivery. In 1885, this guy, Corning, was administering intrathecal anesthetic. 1901, intraspinal morphine. Hop ahead to 79, morphine intraspinal for cancer pain directly. 1982, Medtronic introduces targeted intrathecal drug delivery. But in 91, they released it to the US market. So back in 82, they reported that, yes, we've done this. In 1991, it gets released. And then there was this long period where they were kind of the only guys on the block. In 2012, Medicis was given FDA approval for a new intrathecal drug delivery system. And so this is what we all deal with. This is kind of what we see. Again, I'm an interventional radiologist, and what I do in my practice is really interventional spine. But I can't tell you, there's probably 20% of my new consults who call and say, hey, I need somebody to take over my drugs. And my office knows I don't administer meds. I do not prescribe. We can talk about how we can make your pain better. We can talk about some of these other things that probably are components that drive your pain. But thinking that you're going to kind of just come up and I'm going to resume prescribing you medications, it just doesn't happen. And a lot of those patients then don't show up. So, but this is kind of what we're really facing is that I think for so many years, the practice was a person comes in, you give them some pain medication, they come back to no better, they get more pain medication. And I say this, I really embrace the physical exam. But I have patients who tell me in 4 or 5 years of seeing physicians, they've never been touched. Now, is that exaggeration? I don't know, but I've heard that story more than once, that they've not gotten physical exam. They've not been percussed or listened to or had limbs manipulated. So I think just kind of based on, this is not necessarily the medicine part, this is the humanity portion. People sense a disruption of barriers between other humans when you're allowed to touch. That person's coming in is sharing something very intimate with you, that component of their pain. So when you extend and touch them, talk to their family, know them by name, it's a huge component. I had a lady that came back to me about 2 weeks ago, hadn't seen her in forever, but she needed pain meds, so her doctor sent her somewhere else. She said after about 3 or 4 months of being followed up, she walked in the office and they still didn't know her name. So when you can just do simple things like learn a patient's granddaughter, you know, the fact that this young lady, this one patient, she loves her granddaughter. She brings in pictures from Disney. When you make that connection with the patient, you've moved beyond, I'm that person, injecting them, sticking them. I'm a person that's intimately connected to that person. And it's, to me, again, it's why I practice medicine, to kind of engage those people, not to just actually stick them. And as you kind of see right there are going to be components of this talk that I think I will clearly outline as this is science. There'll be scientific backup. But there's huge portions, if you're stuck in this room with me for the next couple of minutes, where you're going to kind of hear my opinions about things and some of the things that I think that I've seen that are not quite on target for who we should be. Again, these are my opinions, but who we should be as healthcare providers and who we should be as, if you really kind of look at the kind of Kim Kardashian, I hope I'm not stepping on any toes, but this whole kind of reality TV world that exists, there's complete absence of humanity being practiced. So outside of just being able to take care of people, take care of their families, I think is a huge opportunity we have to kind of reinforce humanity even for that 15, 20 minutes in people's lives. So what does pain look like? This is kind of my typical practice. In the morning, I'll see a little bit of spine, but then I'll do an angiogram. I'll go to the hospital. I do some, you can kind of see this guy had a little renal cell carcinoma. So I do local regional ablation, either microwave or cryoablation for that. But then I think most people who have an other knows that kind of pain. I was dealing with some of that pain this weekend. That kind of chronic pain. You know when you've been out of town for too long? That's the definition of chronic pain right there, man. It's like, oh, honey, I'm going to do this, I'm going to do that. And then you know those words, right? Can we talk? We need to talk. I know for me, for my wife, when she goes to one syllables, I'm in trouble. It's like, yeah, you hungry? Yeah. You want to get something to eat? Sure. It's like, oh, what? It's like, what have I done wrong? But yeah, I told you, that's chronic pain to me. If we look at prevalence of pain, this is just an excerpt from cancer pain. And largely, like I said, I started predominantly in cancer pain. And if you kind of follow this breakdown, if we look at a prevalence of about 1.5 million patients, a good portion of those continue to have pain. half of those have severe pain. And if you really look and you talk to the oncologists, a lot of times they think that they're doing a great job with pain, and you know they have their pyramid and everything. But when you talk to the patient, a lot of those patients are not getting appropriate pain. And so when you look at a person with a life expectancy of greater than 3 months and significant uncontrolled pain, those are the patients that we're really targeting for targeted drug delivery. So again, like I said, 1991, Medtronic came out with their pump. And this is kind of the classic pump design from Medtronic's standpoint is you have a pressurized component that is the pump itself that we fill with the medication, okay? That goes through a filter, and there's a peristaltic pump. And if you will, there's basically a line that has a rotor running over it. That rotor delivers medication kind of as a continuous dribble, if you will. You have a catheter access port for that, and then that goes out to the catheter. The new system that Flowonics uses, one of the things, again, this is kind of my bias, but being a person that refills these, one of the things that I like first is that there is a tactile sense for their pump under the skin. I can run my finger over it, I can feel the difference, and I can feel my port that I'm going to be placing my Huber needle through. Has a filter, but then it has a precision delivery system that is made up of a couple of specific valves and a dosing chamber. So this valve, as I understand, is really kind of the key to how medication is delivered. It's not delivered in that kind of constant peristaltic dribble component based on the concentration of your medication and the dose you're delivering. That then determines how long this valve is open based on those two known factors. So the length of time opening then delivers your medication pretty forcefully, but it does have a velocity check on it, and that this flow activated valve, if it were to see the medication moving through too rapidly, it would close, preventing that medication from being delivered. But this medication is now delivered in much more of a bolus format through the catheter. And Flowonics pump does also have the catheter access port. So to kind of see what I'm really saying, if you were to take a concentration 10 milligrams per ml of, say, morphine, and you were to deliver a milligram per day, in the Medtronic pump, that's delivered as a constant rate. However, in the Flowonics pump, based on the fact that it's delivered in those boluses with complete closure and no drug delivery between those bolus, you're getting these microaliquots. So you're getting 2 microliter boluses every 30 minutes. So that affects how the medication is delivered. So having said that, now, I always get a lot of medical companies that will come to me and they'll give me their new latest, greatest. And a lot of times when you're hearing the new latest, greatest, I mean, it sounds great. That's why they have marketing teams. But the biggest thing for me is, does that make any difference in how patients respond? Is this new technology gonna make me be able to care for my patients a little bit better? So it all boils down to me, how this drug is delivered in the intrathecal space. So if you look at drug distribution and you say you go with the typical peristaltic, this was an exam that was set up where in a swine model, you had an 8-hour fusion with your catheter tip at T12. It was delivered in these different volumes, and basically they tracked the volume of distribution of methylene blue linked to a drug as it moved through the CSF space. And what you really get to see in that typical peristaltic delivery is that a lot of the medication got delivered right around the catheter tip. Volume of distribution, and this is immediately adjacent to the catheter tip. This is the opposite aspect of the spinal cord. You see very little staining there. So the majority of that medication stayed right at the catheter tip. Now we're going to come back a little bit later and we're going to talk about granuloma formation, because that was one of the biggest things. When I first started doing pumps, I had this huge fear that based on my drug delivery, I was going to cause a granuloma formulation at the tip of my catheter. So it was like, what can I do? If you look at a lot of the early literature, it's linked to specific drugs, higher pHs, higher concentrations. But sometimes this can be really disabling. It requires neurosurgical intervention. So this was kind of the big fear for me in placing pumps. But basically what you see here in that kind of typical peristaltic delivery, the larger portion of your medication really was delivered right around the level of the catheter tip. So does design of the pump play into, or how does it decide distribution, that volume of distribution? Well, when they look to now, we're moving away from that peristaltic delivery, looking at that volume gated delivery, and what you see is you get increased rostral spread, and looking at it at an 8-minute period, volume of distribution via the bolus delivery was 16% larger than the continuous delivery, and by 16 minutes, that volume of distribution had increased by 30%. So again, now, so the next question, we see that there's a greater volume distribution based on this gated delivery. How does that affect patients clinically? So again, you're gonna be forced to listen to a little bit of my philosophy. When I was in the Air Force, one of the things that the Air Force was really good about is you could get up to 2 weeks vacation from the Air Force free to go out and deliver healthcare wherever. So based on the churches I was attending, they had a Philippines mission. So I started going out just kind of seeing what I can do, because this was very informal. I ended up at a hospital one day in Manila, and it was kind of on the outskirts, but I go to neonatal ICU, and the windows are open, and it's adjacent to the trash dump. So there's flies flying in and out of neonatal ICU. So one of the things we do in the military is if you go in and you have to set up a field hospital, one of the things you have to do in hospital design is you want to move, you don't poop where you sleep. That kind of basically is kind of, so I talked to the hospital administrator and said, you may see a different infection rate if you move this away from, and I come back next year and it was right. And that turned into a medical mission. So for the following 2 years, I went out, you can kind of see we're out in the jungle. This is kind of where people live, but people would come up and see us. And I got sponsored by an ultrasound company, so I go back to my tent every night with a generator and recharge a stack of batteries, and I would do ultrasound out here basically in the jungle. And this lady came to me sick, but her sickness was that little alien growing inside her, so I got to tell her, well, in about 8 months, this was probably gonna be over. But I put this here because a little bit more of my story. I had been at hospitals forever. I'm in a solo practice now, and the reason I'm in a solo practice is because I had been in hospitals forever. And I reached a point where we were just running into problems dealing with each other. And what I would find is I find myself in the hospital hour 14, hour 16, all my partners are gone. And the reason I'm still there is because the way I practice. I always made my practice, even though I belonged to different groups. I wasn't a group practitioner. This was my practice. So how people saw my practice was based on how they saw me. So if someone needed a consult at 8 o'clock at night, after I've been in angios all day, I went and did it. And that drove a lot of my practice, because when I finally said I can't deal with this anymore and I opened up a private practice, a lot of those physicians who remembered my work at the hospital continue and then start to actually bypass the hospital to refer to me. So now, we're in the middle of a great build out, and it's been really great. So one of the things that I say, and this is just me, new fellows going out, a lot of you probably will be going to groups, and how you negotiate some of those some of those tough things being the new guy in the group, because I got a lot of those new guy things and I just took them and tried to run with them. But they become these games we can play with ourselves of how do I deliver excellent service? How do I become the person that shines a positive light, not only on myself, but as you shine a positive light with the thinking that I'm shining this light for my group, that's gonna reflect on you, you know? And later on, you don't know where that will come in handy or where it will be a benefit for you. But so many times when I stayed and did that little bit extra because I was helping out a colleague but doing the right thing for a patient, a lot of those rewards have followed me now. So I showed you that case of that renal cryoablation. One of the urologists that I had helped, he sends all his renal cancers to me. He sends all his difficult renal cases to me. And that's kind of enabled me to build that practice. So I don't know if anybody's read that book by Simon Sinek, Start With Why. When you get lost sometimes, I think that's a really important book, Start With Why. But it's why do we do what we do? Because happiness and all that's going to change. We all have these ideas of what medicine is going to be to us, but you're going to find yourself in those situations that are just going to suck. And really your definition of who you are and why you're doing what you're doing is what's really gonna kind of guide you through those tough situations. So whenever things start to suck for me, I always step back and I go, why am I doing this? Why am I doing this? I'm not doing it for the money. I'm not doing it for the fame. I'm doing this because it's the right thing to take care of people. This is my way that I share and kind of expand my humanity. So whatever it is, you're gonna get out there, I can guarantee you, within the next couple of years as the new guy, as the new person kind of in the practice, when things start to suck, just remember why you do what you do. So remember before I was saying, okay, we have a greater volume of distribution happening in the CSF. Is it really impacting, though, the quality of pain relief that patients are receiving? And remember, I talked about with that peristaltic delivery, there was always this fear. I think up to 6 to 8% was quoted for granuloma formulation around the typical peristaltic delivery. Dr. Pope did a study that really kind of tracked these, looking at 402 patients who had the gated delivery pump implanted. And what he saw was less than, right at 0.25% granuloma formation, 1 granuloma in 402 patients. And when they looked at the compounded medication that had been placed in the pump, the concentration was really off the chart. It was something that you would not normally place. Most of the time, if I'm running a 20 ml pump, 2 to 3 milligrams fentanyl per ml is really high. The majority of my patients are really starting out anywhere from 250 to 500 micrograms per ml. And by the way, that is off-label use. I'm saying that this is off-label use. A lot of what we do is off-label because most of the pumps, if you look at Medtronic, they've been cleared for a couple additional medications. But Infumorph, preservative-free morphine is what most pumps from FDA labeling are cleared to run. But as you get out there and you start looking at some of the polyanagensic consensus, there's first and second line medications that we run. But when you looked at this 1 granuloma, the concentration was off the chart. And also, some of the things that they saw was when you increase the pH and the concentration with certain medications, some of the other pumps were shown to actually start to malfunction, start to have some leaks, actually start to have some corrosion as well. And that wasn't seen in the valve-gated pump. Also something that came out that's pretty significant, and I've seen this in my own practice. So you'll have patients who may have had say a Medtronic pump, and you place the valve-gated pumps. One of the things that we've seen is that we will typically lower the dose of the medication that they've been delivered, and typically as much as 10 to 20%, where we will lower what they were getting. And we're seeing that a lot of those patients continue to do quite well. And this is reflected in the data. And I'm going to break that down over the next couple of slides just a little bit more because I think that's pretty significant. So in valve-gated, and these are patients who've undergone revision, you see that there's about 20 to 30% less dose with the same VAS score in these medications. And some of the dose escalation that you see, specifically in like hydromorphone, is pretty significant when compared to peristaltic and valve-gated delivery. Another point is we've looked at this periodic bolusing. So basically, I don't know if you remember that slide where I showed you that the peristaltic kind of delivers it in one continuous flow, but that the valve-gated kind of delivers these microboluses with no medication delivered between that. What they've shown is with that type of dosing where you deliver medication periodically, there's actually a reduced medication use overall, so we don't see the dose escalation, because one of the things that you'll see after you place a pump is people will start to require more and more and more. And then you have to ask yourself, are they requiring more because their original process that the pump was placed for, is that worsening? Or are there some other issues going on? But with the valve-gated, we don't see that dose escalation. Now, an interesting story, I went to a Vertiflex course last week, and they were describing a pump patient who had received a pump in some outside practice, and they said, well, you know, it was that typical pump patient that gets a pump placed, and it just gets increased with no evaluation of the patient. And what happens, the patient had developed some component of central stenosis, and they just kept upping the pump. So, and we'll talk a little bit about this shortly when we talk about practice development, but one of the big things to remember, if you do get into the practice of placing targeted drug delivery, that patient is a system, and they're more than just that one thing that you placed a pump for. I have a young lady who came in, she had multiple compression fractures. We did some things for her. She ended up going on to have spine surgery. About a year later, she comes back, just intractable back pain. I ended up placing a pump for her. She ran with that pump for almost a year and a half, no dose escalation, but then suddenly presents to me just, you know, tearful, I can't sleep at night, this is terrible. Again, physical exam didn't just up her rate, and she was having facet-mediated pain. I did a facet block and followed that with rhizotomy. She gets about 6 to 8 months of relief from that now, and now she knows that pain. My left hip kind of achy pain, my leg is back. I repeat medial branch block and follow her with rhizotomy. We've been doing that for approximately 3 years. So the thing to remember, and what's significant again, this is your practice and you want to take good care of patients, but there's nothing wrong with making money either. So if you come in and this patient, you're refilling their pump, you're seeing them routinely for their pump, don't lose the fact that they're an entire system, because those patients are going to come back with other issues. And I even see this in my cancer patients. Just because they have, you know, renal cell carcinoma, they're still going to get spine degeneration. They're going to get facet pain, and everything on that right side isn't going to be recurrence of their cancer, even though I have to rule that out. Sometimes a facet is just a facet, you know, so don't lose that. But the bottom line of this slide is we've seen with periodic bolusing that people don't have the dose escalation, and I'm able to run them at lower doses and have a stable dosing for them as well. Not just pieces of cancer pain, we kind of talked about this before. There are a huge number of cancer patients out there with uncontrolled pain that's not being satisfactorily controlled by their oncologist. And I talk to other pain physicians and other people doing pumps, and we just ask ourselves repeatedly, why don't we see these patients? I don't understand. I go into offices, I talk to oncologists that I know, but an interesting fact, at my previous hospital, I got the majority of my pain referrals from the pharmacist. The pharmacist would come to me and go, hey, can you go and see this patient? Because they're eating our daily supply of fentanyl. You know, they're eating our daily supply of Dilaudid. And what happens is these patients come in, they're in intractable pain, and they're running through all the hospital's narcotics. And I've literally gone into people's rooms who are having IV drips running of Dilaudid, and one guy was on the floor, balled up in a knot, screaming. We ended up placing a pain pump on this guy. But again, if you're an oncologist and you see your patient like that, and you know that someone does intrathecal drug delivery, why wouldn't you refer that? I haven't been able to fully crack that nut. The majority of the pain that you'll see, a lot of them is polyostotic-based metastasis, but pancreatic cancer tends to be a killer, obviously, but the pain component also looks like it's very deadly for patients. Touch on that kind of shortly. Majority of patients that, if you look at the United States, Japan, and you look at Europe, based on these different types of pain, you see there are huge portions of their patients that are undertreated. I threw this in to kind of bring up this point. We know what's going on with opioid epidemic in this country. 2014, they quoted 19,000 patients. I saw 2016 data that said upwards of 27,000. So the process is not getting any better. 2 randomized control trials that looked specifically at cancer patients who had conventional medical management and targeted drug delivery. 2 points that reached significance was pain reduction and reduced toxicity associated with intrathecal targeted drug delivery. But look here at the survival difference at 180 days. It nearly reached significance. So keep that in mind. If you deal with any type cancer board, it's almost everything you do. You go to tumor board, it's multidisciplinary. There's usually somebody there banging the NCCN guidelines, and that's really kind of how we manage cancer in this country. And by NCCN guidelines, their new line is the intrathecal route of opioid administration should be considered in patients with intolerable sedation and confusion. So the majority of patients that have come to me, when they have come to me from the oncologist, have come because they weren't tolerating their therapies. They weren't able to tolerate, they weren't able to stay on the table for radiation. They weren't able to tolerate their chemotherapy. As you know, most chemotherapies have some relationship to performance status. You fall off of your performance status, you can't continue your chemotherapy. So I've seen some patients following their inability to stay on protocol. The other thing that you see is in people with poor pain control, their overall use of the healthcare system is increased. Everything from ED visits, inpatient, outpatient, their lab requirements, and then transition to hospice. So I had been in Stockton and I went to a cancer center in New Mexico Cancer Center, and this was a patient. I kind of sum it up. 52-year-old lady came in, she had breast cancer. You kind of see what she's on, 200 milligrams of morphine. And I've seen people amazingly on 500 milligrams of morphine equivalent per day. I trialed this lady, she had her pump placed, and when I left New Mexico about a year after implant, she was on 2 milligram morphine a day. And this lady had been a professional ballerina, was very involved in her community. I don't know if it is, outside the outskirts of New Mexico, there's a big mountain range, the Sandias. It's kind of a big hiking spot. And this lady loved hiking up there, but when her bone pain was really at its worst, she wasn't really able to leave her house. When I left, she was back to hiking the Sandias, and like I said, on 2 milligrams of morphine per day. So again, anecdotal, but in your practice, you will continue to do the things you see that work well. So basically, how's the pump done? Obviously, this is done in an OR setting. The patient's usually placed in a decubitus. I like to actually make the incision access down to fascia, stick them from that lateral, and that's really kind of the big thing. Once you have access and you can secure access with a catheter, at that point, patients have been on MAC, and I'll do a spinal block, typically about 1 to 1.2 ml of 0.5% bupivacaine. And then they have a really nice spinal, they handle the rest of the procedure really well, and they transition from recovery really, really well. once you have your pump pocket created anteriorly, and I will go in with most of those patients, I make a mark, because as you place the patient into decubitus, you see that tissue moves. So having it pre-marked where you'd like it to go is a huge next step. After I've created my tunnel, my anterior pocket, I'll tunnel the catheter. And then again, for what it's worth, when I first started doing this case, I always tunneled from the back forward. But when you tunnel from the back forward, think about the patient's anatomy. You have a person, most of us are not svelte, so you have a little bit more front than you have back. So with that, what I found myself was when I approached from the rear, I had basically, because I had approached them posteriorly, I had a very sharp angle coming up. When I passed from posterior to anterior. Then I had a long run anteriorly from where I came up over that hump to where their pump pocket was, because again, they're decubitus, so most of that tissue is moving, okay? So what I found out I do after I had everything tunneled, I'll go in with something like hemostats. I'll create a plane in the back near my access. I then tunnel, because now I have that long run from anterior, then I have that short drop to the pocket, but now I've created a plane for my tunneler to exit. So it gives me a very controlled exit into that plane. And just something, I mean, I've been doing this for years and years and years, and I still always did it, and I'd struggle from the front, and I'm twisting up tunnelers. Now, that little step of just going from the front to the back, it probably saves me a couple of minutes. So then you'll connect the pump, and one of the things that I cannot get away from, because I have a very harassing rep, is that up front there's a catheter access port, but it's a good thing. Once I'm connected with the catheter access port, I'll just access that with a specialized needle, do a little aspiration, which proves I am still within the intrathecal space, because I'll get that nice flow back of CSF, because there have been cases where you thought you were still in the CSF, but due to manipulation, you no longer are. So that's really a great check prior to placing your pump in the pocket. I irrigate the anterior pocket with antibiotic irrigation. And I really believe in copious irrigation. Once it's placed in this pocket, secure it within the pocket, close two-layer, typically interrupted, then a running monocryl, and I'll do the same in the back. And then, like I said, this is actually showing the Medtronic pump, where you have this really kind of nice template. But once a lot of the perisurgical kind of edema kind of goes down, with most of my patients, I'm able to actually palpate the access port. Then the Huber needle gets placed. And finally, I kind of talked a little bit about pancreatic pain. And this was a study done by a colleague in Kansas City. So looking at pancreatic cancer patients, if you look at a person that presents with stage 4, the data says that their survival is about 2.5 months. When it's there, the visceral pain is just absolutely amazing. Patients suffer pretty significant. So he looked at 18 patients. You can kind of see the female breakout, look at their ages. You can kind of see the race breakout as well. But the significant thing is here, intrathecal patients had a median survival of 12.5 months. Now, if you remember those 2 randomized controlled trials, they did show about a 180-day difference in survival that nearly reached significance. But based on the quoted literature survival of 2.5 months, that's a significant difference. And it's not only just a significant difference, if you've gotten good pain control for those patients, this is a significant improvement in quality of life along with survival. And I just think about, I try to imagine myself in that spot where you're kind of really at a very clearly defined end of life point. I want my quality of life to be as high as possible because I want to interact with patients as much as possible. And I've had pancreatic patients where I placed a pump in this guy when I first got to New Mexico. I saw him back at like 2.5, 3 weeks. He had gained almost 12 pounds, but he was in the office with his wife and his 2 daughters, and they were all pissed. And I'm like, aren't you doing better? Yeah. I'm like, is everything okay with the incision? Yeah. his question was, why did you all wait so long to do this? Because I suffered so significantly. And that was such a huge thing, again, anecdotal, but it just struck me that this guy had such a significant change in the quality of his life. And I've talked to patients who've told me, if I knew I could have good pain control, I would never have gone through chemotherapy. One lady told me I'd have took all my money and I would have taken all my kids and I would have just traveled until I dropped. And I think kind of, you know, for me, if I were faced with that situation, I would want the best quality of life and I would want to try to live and be around my loved ones as much as possible. So again, I just can't figure out why we don't see more. And the other thing to remember, cancer with good control now is becoming a chronic process. So if you get cancer patients in your practice, remember to consider all the other things that people with cancer go through. They get back pain, they get hip degeneration, they get knee pain, and so from a business standpoint, when I opened up my office, well, I'm in the hospital, like I said, I'm doing my thing, and I'm closing now because I know you guys are tired of listening to me. But I'm in the hospital kind of doing my thing, and I'm just like, wow, I'm really feeling like underappreciated, overworked. I'm breaking out of my 4 o'clock case, and all my partners are gone. And I'm like, man, what am I still doing here? So I'm out at dinner one night, and this buddy is telling me about another buddy who has an office. Just at that moment, that guy he was telling me about walks into the restaurant. So I started talking to this guy. He says, hey, I got 2 rooms in the back of my office. I'm using them for storage. Would you like to use them? I go, yeah, great. So the other buddy who I was with, he said, yo, man, I got 2 exam tables. You want them? I was like, yeah. I said, yo, man, because that's how we talk when we be talking. But anyway, he gave me these 2 tables. So now I clean out this exam room, and he's got all his stored paper files in it, and I'm just waiting there. I got 1 day off from the hospital because they would only give me 1 day. He gives me 2 patients. So I see these 2 patients, but right now it's still kind of fun because it's just a day off and I got to see 2 patients. Well, then that grew to like 6 patients, and as I was leaving that afternoon, because I had no more patients, the MA gives me this envelope, and I open it up, and it's cash. It's like, what is this? She said, oh, they have co-pays. I'm like, because when you're in the hospital and you're working for a group, you don't know about co-pays. I was like, they give you cash? That's what's up. So I was like, man, yo, I got cash. It was like, man, Starbucks. It was like, venti, give me venti. Shoot, it's a venti day, cuz. And so I'm like, man, I get home, and so we played with that 1 day for a minute. Now, my wife used to run the radiation oncology department. So now I got like 6 patients, 7 patients, but then I'm doing cases. I was like, well, I can't do them in the hospital because the hospital, they're hating me right now. So I get privileged at the outpatient surgery center, but everything's sucking. So I'm just head down, and I was like, can you help me? So my wife takes over. So now dinner becomes, we had this little box with our little 4-in-1 fax machine. And I come home every day and I look, it's like, do we get any more referrals? Because then we started getting referrals. They said, you got 2 referrals. I'm like, that's what's up. So the next thing I know, that grew and grew and grew. Basically, I outgrew that guy's office. And so then I went and got a space and put in 3 exam rooms and a little OR, got a little nice renovated machine. I'm doing injections. But that's what drove my practice initially, was doing injections, because again, it takes a lot to be able to get into another hospital to do interventional procedures. But eventually I got into another hospital through their non-compete. They let me in. I started doing angio cases there. That kept growing. And this month, we'll finish a 6,000 square foot space with 2 ORs, 6-bed recovery room, blah, 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 blah. But it's just a complete blessing how step by step by step. But the thing that saved me in a lot of those places were physicians I had interacted with positively before. They're like, hey, you're still around? Because they thought I just left. They're like, you're still around here? Hey, I'm gonna send you a case. Or I run them into them, and so next thing you know, we have this practice where I'm again in trouble most of the time because I keep doing cases when the one who helped me build it wants me to come home. But it's a great problem. It's a great problem to be able to take care of that. And last week, this is kind of a definition of who we are. We had a lady walk in, and I hadn't noticed it, but she walked in. I hear all this commotion, and she turned 100 on her appointment day. And so we got her a sash. My wife had bought her a little cake and got her a tiara. It's like her whole family's like crying. We're crying, and that's why we do what we do. Happened accidentally, but those relationships that you forge along the way, be careful, because you're making a positive or negative impression on someone. And it's not just family. I mean, it's not just your colleagues. Family members of patients have helped me along, and the majority of what we do has been word of mouth. So new fellows getting out there, remember, it's your practice. You kind of under somebody else's moniker now, but those relationships that you're forming now, they will potentially follow you the rest of your life. And so you can't unring a bell. So ring it positively. So questions? Yes?
I was wondering at what point
7.
procedure do
Oh,
you
one of these days that's going to be the right answer, and they're going to be like, "He's amazing."
do you place the spinal? When you
Oh, so most of the time, with a good local, and I get intrathecal access with the catheter. So it's a large Tui-like needle. I get intrathecal access. I get that clear flashback of cerebrospinal fluid, and then we have a little blunt needle in our kit. I'll give that, based on size. And it's something too, I work out with my anesthesiologist, because you give them that sympathectomy. And I like my anesthesiologist to know that's why her pressure is dropping, so they're ready. But yeah, so I just let them know, hey, and I'll clear it too. It's like we have, a little Asian lady is not a 400-pound, 300-pound guy, so.
You get your intrathecal access and then you make your pocket afterwards.
Well, I made my in the back, and I used to do that. I would get my access, but then as you're bovying or doing anything, the needle's just in the way. So I get a clear, once I've kind of marked where the interlaminar space that I want to enter, I make my incision, I dissect down to fascia there. When that's clean, then I get my access. And then once I feed my catheter up to the level, I'll then give my my spinal. Yes, sir.
As far as trial, so you do just bolus trial?
Yes.
And what determines, how do you determine the dose of that? And do you hold your patients after the bolus?
I hold my patients typically around an hour. I have some people say they hold them overnight. Some people hold typically about an hour. One of the biggest things that you can do for your patient, no matter what your dosing is, the initial intrathecal injection is associated with mast cell dehiscence, so they itch. So I warn them that it's like they can deal with almost anything, but if you don't tell them about that itch, they become pretty annoyed with you. So I tell them about the itch, and I will give them Benadryl as well. I'll give them 50 of Benadryl. But depending on, say, a lot of the patients that I'm seeing now are post-laminectomy syndrome, so really bad pain. If they are patients that have significant components of spasm that I've documented over time, and keep in mind too, very rarely am I just initially placing these. I've seen these patients for some time, so I have some familiarity with their background. But if I know historically they have significant spasms, I will include a small test dose of baclofen. And then typically I'm running right around 100 micrograms of fentanyl.
So for that bolus, though, what's the dose that you normally give?
100 mics of fentanyl, typically.
You don't start with morphine? You start with
I have, but now that I don't have the fear of forming granuloma, I used to use Infimorph all the time, but I can just tell you from my experience, if you see a guy that has 6-level fusion and you're trying to do his epidural and it's like you're stabbing through concrete, I know I end up with some component of fentanyl and baclofen on those patients. And so you can kind of work through it, but again, anecdotally, it's what I see.
you already touched on it a little bit, but what medications or combinations of medications do you administer intrathecally?
Majority of my patients are fentanyl. If there's some significant components of spasm, a baclofen. There are some patients who, just for whatever reason, don't really tolerate or like the fentanyl, and they will typically end up on morphine, and then bupivacaine. Bupivacaine is typically running in the background, and you saw the pancreatic data was from a guy, Dr. Kloster, who really kind of took away a lot of my fear for using bupivacaine. It's just such a powerful adjunct, and also I did a lady who had disseminated breasts, and she had a lot of neck and upper chest involvement, and I placed her catheter at like C3, C4, and infused relatively high doses of bupivacaine. She had lymphangitic spread to skin, and it was horrid. But we got good pain control for her, and she passed pretty peacefully. So I have used pre-alt, but I've had a lot of goofy patients with pre-alt, and patients that I kind of tried multiple medications, and I end up on pre-alt, and then I end up back. So again, in my recent, say, 2.5 year history, maybe 60, 70 plus patients, 1 or 2 pre-alts, and it was pretty, yeah. And you do what you know, so could it be that pre-alt would have worked on other patients? Yeah, but your practice is very much anecdotal.
What are non-cancer pain indications that you're putting in the hospital?
Most common, I know they don't like this term, failed back syndrome. It used to be failed back, but post-laminectomy syndrome probably is number 1. I've gone through a rash of chronic pancreatitis, like 40, 50 bouts of pancreatitis. You look at the dense calcification on CT. Pancreatitis. Oh, I've actually gotten several patients who postherpetic neuralgia. You just really can't do anything else for it. And I had a lady, S1, S2 distribution, and so she couldn't even sit the whole time. She's just miserable on her side. We placed her the next day. I walked in the room. She's reading her newspaper on an iPad, sitting flat on her butt. Postherpetic neuralgia has responded really well.
With fentanyl?
Yes, with fentanyl. And bupivacaine, I will err heavy on bupivacaine. And when I say err heavy, a lot of times patients may be on, she may be on like, what is she? I think she's like on 100 micrograms fentanyl per day with 2.5 bupivacaine per day. But what a lot of my colleagues are starting to suggest is that this bolus dosing really is the way to go. If you think really about kind of sensory adaptation, when that nerve is constantly being bathed in the medication, whereas you allow it to maintain its naivete as much as possible. So it's naive to the medication, and it sees it in these boluses. And so after a bunch of conversations, I think that's going to be kind of one of my next things that I really get into. Yes, sir.
As far as tip placement, do you try to get it? You had mentioned, they're having the pain here, so put the tip there, or do you have I always put the tip there?
Well, the thing is, what I tell you, I've gone through a rash. Probably the last 60, 70% of my cases have been some relationship to post-laminectomy syndrome, and that's typically lumbar. So a lot of T8 placement. When I was seeing a lot of cancer and seeing a lot of pancreatic, I was placing it higher in the thoracic column.
Favorite author? Favorite author?
Hemingway. Yeah, I deployed for Desert Storm, and obviously the first one, it never really became what we thought, but they had put me on a British base in a 1,000-bed hospital, and they had a great library, and I came upon Old Man in the Sea, and then I was in love. But I don't know if you've seen the recent Woody Allen movie. The guy with the crooked nose plays. I'm blanking on the name of this movie, but it's set in France. He kind of goes back and he meets all the authors in France, but so he gets to hang out. What is it? Yes, that movie has. I mean, I'm like every 3-4 months I have to watch that movie, but just to see Hemingway's prose as he speaks and see his interaction with F. Scott Fitzgerald, which is probably my second. But just the simplicity in his prose is awesome. So, yeah, I can't impress upon you guys enough. This is a very, once I got pain pump in my hand, in my hands, it changed my interaction with people and interaction with people's lives so powerfully. What we do as pain physicians is so significant to people's quality of life. And, it's great. You can live another 1, 2, 3, 4, 5 years, but if you're not able to do those things that bring that quality of your life, which is typically personal interaction and activity. So I think we stand at a place where we have ability to impact people's lives pretty powerfully, and it's why I practice medicine. I like the fact that this provides a comfortable living, but at the end of the day, I drove the same pickup truck for almost 16 years, so it's not, I don't have a huge financial demand, but when you see that and that what you did directly affected and impacted people's lives and the lives of their families. And I get cards, I get letters, these people a lot of times they pass, but they know how I like to read, so I've gotten great books. I've gotten old manuscripts, and people will come in and they want to share that last little piece of their loved one with you, and it's why I do what I do. So excellent. Thanks for your time, guys.